Right. Yep. Good evening, everyone, and welcome to our seminal sixth series. Thank you for attending. Today we're going to be focusing on chronic pancreatitis. If you've got any questions, you can use the chat button to put any questions there, and then we'll pick them up at the end if we've got some extra time. So today we have Prof. Chris Halloran. For those who don't know, he's a professor of pancreatic surgery working at Liverpool University Hospitals. He's done a lot of work in pancreatic surgery and pancreatitis as well. And he's a professor at the University of Liverpool. He's one of his quite prominent works is that he leads the Europac um, incentive. So essentially, it's the European Registry of Familial Pancreatic Cancer and hereditary pancreatitis, which essentially allows for early detection of pancreatic cancer that is inherited as well. And also, he's also played a very important role in creating minimally invasive methods to treating severe and chronic pancreatitis. So I'll give the floor to Prof. Halloran to enlighten us about all his work in chronic pancreatitis. Thank you.
Okay. Thank you very much. As you can tell, I'm in theatre, and I might have to leave at some point, but hopefully I've got 45 minutes to do this. So, disclosures. Sorry, this talk is going to contain some genetics. I do wish I could take the credit for that wonderful diagram there, but I can't. But I think that sort of sums things up quite nicely. So. The first paper I would like to talk about is probably the most important evidence that we use when we talk about hereditary pancreatitis and its relation to chronic pancreatitis, done by the polymath David Whitcomb, who works in America. Now, as you're reading through that, you're going to come across some words that are going to make your brain hurt a little bit. So I thought I'd summarize some of these for you. So Genetics 101 is the first thing we talk about all the time are probands. And the proband is the first person in the family that either has the medical condition or has the genetic mutation. Okay. The second word, which we will drag back from O levels or GCSEs, is heterozygous, which remembering, of course, you have two versions of each of each gene called alleles, and one comes from each parent. So in this case, this would be the red allele from that jelly bear here. Okay, so they will be two different ones, and they sometimes can have a mutation in, which would be one, and if they both have mutations in, it's called homozygous. Penetrance is the proportion of which that genotype then gives you the phenotype or the signs and symptoms of the disease. And then lastly, we talk about autosomal dominance, which is how much of that mutated allele gives you the necessary trait for the disease. So if we come back to this individual with the red half, you can see that can give that genetic predisposition to their children either three-quarters risk, a quarter risk, or a half risk. Okay, so that's our starter for six in understanding this. So what David Whitcomb discovered was that a mutation in PRSS1, which is cationic trypsinogen, gives you this quite rare hereditary condition called hereditary pancreatitis, where people are getting the disease at a very, very young age in childhood, and it cripples them then for the rest of their lives. So essentially, what is happening is they're getting symptoms of recurrent pancreatitis, which develop into chronic pancreatitis over time. The heterozygous mutation in the cationic trypsinogen gives them a gain of function mutation, and within that pathogenic variant of PV, and then gives them the phenotype of hereditary pancreatitis. Now, remembering, of course, that all mutations within cationic trypsinogen cause some form of premature trypsin activation, and the sort of pathogenic variants that are often bandied around that everyone sort of has some vague memory of when they're reminded are are the mutation here called N29I, which auto-activates trypsinogen, the R122H variation, which increases trypsin stability. And they're really the two highest penetrant pathogenic variants. And then there's also this one here called A16V, which is pathogenic, but its penetrance is limited, such that you can have completely asymptomatic parents that give this down to children, and vice versa, which is worth remembering. But essentially, it's the symptoms plus a gain of function pathogenic variant, which will give you hereditary pancreatitis mostly. It might probably worth at this point just having a few different learning points so that we actually understand what all of these things mean. People often say to me in points in time, and they group everything together and call it genetic pancreatitis, which I think is a bit nonsense, to be honest. Sporadic pancreatitis, which is just your common or garden, is due to ethanol or tobacco abuse. Is becoming more common in people that use high dose nicotine vapes, especially at the sort of 15, 20 milligram level. It can be caused by COVID and autoimmune disease and any obstructive disease. Then comes the scenario of idiopathic pancreatitis, which either becomes recurrent acute pancreatitis, leading to recurrent chronic pancreatitis. And these can be caused by mutations within serine protease inhibitor Casl type 1, which is called SPINK1 mutations. Which basically is a disease modifier, not very common, and then CFTR mutations, which are cystic fibrosis transmembrane conductance regulator mutations. So this is a cystic fibrosis mutation. So these, as opposed to hereditary pancreatitis, modify a disease from something else. So it causes that disease, chronic pancreatitis, like alcohol or tobacco, but these mutations modify it into something that's a little bit more florid. And then, of course, as we've just said, hereditary pancreatitis is a mutation within cationic trypsinogen, but occasionally there are families where you don't know what the mutation is because we haven't actually worked out how to test for it, but it's undisputable because they have so many members with chronic pancreatitis in the family, but they're quite rare. So that's a starter for one. So that led us to understand this concept of hereditary pancreatitis being separate from chronic pancreatitis. David Whitcomb, being the polymath he is, didn't just stop there. He actually developed a whole consensus proposal of how chronic pancreatitis develops from the start. And my view on this is that it's so useful. We should all be sort of using it when we talk to patients and sort of referring back to it. And at the outset, this looks quite complicated, but it is actually quite easy. So that there are patients who are at risk and they have their susceptibility factors. So as we've said before, these are the things that we all know: acute metabolic pancreatitis syndrome from COVID, certain drugs, smoking, ethanol. These are all of our susceptibility factors, and if those carry on for years and years and years, sooner or later you will get I thought I'd outline that. Sorry. The acute pancreatitis syndromes, and which then become recurrent syndromes. And then they enter this sort of doom loop here of early chronic pancreatitis. Now, at this point, it's not too late. You can still enter left and get away with this if you're lucky. But if you have a susceptibility problem here, for example, any of those mutations I've just talked about, possible pancreas disease and possible duct rupture, then this will keep cycling this round and you can't escape left. And eventually you'll run out of room and you'll develop into established chronic pancreatitis over here with the hallmark features of immune dysregulation, acinar dysfunction, islet cell dysfunction, pain, and metaplasia. And it's really this thing that is the biggest problem, because eventually metaplasia will form into pancreatic adenocarcinoma. But we have tried with trials, for example, Europac 2 using antioxidants and magnesium to see if you can try and resolve this back, but also knowing that there are various conditions in this doom loop that exit on the right side, that does give us an option for early detection of pancreas cancer as well. So I think this in itself is such an important piece of work that we have to use this all the time when we're seeing patients and have an understanding of how things develop. The next series of papers, I've lumped all of these together, really allow us to understand how we should operate on chronic pancreatitis, which as surgeons is what the mainstead is. Um, Sorry, I've gone the wrong way there. And we have to appreciate that we need to know if you're crazy enough to do chronic pancreatitis operations, that one operation does not fix all patients, and we do need a couple up our sleeve. The trouble with this is that everyone gets the wrong nomenclature of these operations because they are all variations of the prior operation. So the names get very mixed up over time. But my ex-boss, John Neoptolemus, Jens Werner, and Marcus Buchler from Heidelberg really have written quite extensively on this so that we now understand this. Remember, of course, that no matter what our gastroenterology colleagues say, is that we also have an important role in both the treatment of pain, intervention for complications, but importantly at the end, disease modification. So if we detect something that's going very wrong, if we offer a complete resection, we can stop that progressing into cancer. So I'm just going to diversify for a little bit and introduce this fella for you, who is William Chelsden. He was the first president of the Royal College of Surgeons, and he gained fame for being a lithotomist for removal of bladder stones. And he was reputed in his day as being very successful and very safe, only with a 50% mortality. We of course got a little bit better than that now, but the modern pancreatic surgeon is the contemporaneous stone cutter, because we cut for pancreatic stones all the time. So these are the sort of original, fairly outdated, limited use operations that you'll know. So the first sort of batch of these came in the sort of mid to late 50s and 1960. Duval procedure was basically a left pancreatectomy, and you plug the small bowel in over the end there. So that assumes that actually there's a stricture here and everything's going to drain that way, which was a bad assumption. So that went out pretty quickly. One of his acolytes, Puster, actually realized that probably what you should do is amputate the sort of left colon, but actually open up that duct more widely to actually get rid of all the stenotic areas, but still cover it with a big loop of bowel. And then later, Partington and Rochelle just decided, well, let's just open up that middle part there and plug a rulim on that. The trouble is, as I said, because all of these are subsequent innovations from the last one, everyone gets all these names mixed up. So I had a patient not so long ago that came in and said, oh, I've had a Pusto in the past. I looked at the scan and said, well, you can't have, you've still got your spleen. So I think you've had this. The Partington Rochelle is usually also called a longitudinal pancreaticojejunectomy, whereas a Pusto is sometimes referred to as a lateral pancreaticojejunectomy. As I say, they've got limited use and probably have been superseded by the resectional type procedures. Now, the classic one is a Whipple. So it takes out the head disease. It only deals with head disease, and it's not going to deal with any disease in the body and the tail. And obviously, those sort of came about initially by Kausch in the early 1900s, but were sort of solidified by Alan Oldfather Whipple in 35, and then latterly in the late 70s by Traverso and Longmire, who discovered you can preserve the pylorus. They don't work too badly, but again, they're only going to look after disease in the head. Then in the 80s onwards came the next series of operations, which actually preserved the duodenum for physiological function, but started to core out the head of the pancreas. So this is what's called a classic Bega procedure by Hans Bega. from Ulm. Remembering, of course, that if you're digging out all this pancreatic tissue, there's a couple of things you need to worry about. The blood supply needs to be preserved down in this corner, otherwise you're going to end up with a black duodenum. The blood supply needs to be preserved up here at 11 o'clock. Otherwise, you're not only going to end up with a black duodenum, you're also going to end up with a stenosed avascular bile duct, which will cause you problems later down the line. And then that's just dealt with by a patch over here with a typical sort of pancreatic anastomosis there. The trouble with this operation is that it requires you to be able to get the pancreatic neck off the portal vein, and that's not always easy in chronic pancreatitis. Hence, this was designed by Charlie Frey, which was a sort of coring out of the head, but then extending it up to the pancreatic duct and opening all of that out, which was then further modified by Marcus Buchler when he was in Switzerland, where you don't actually go across the neck at all. You just take out the head bit, which is easier. And then obviously, Isbicki wouldn't be left out of this, so he developed this operation, which is very, very minimal indications in my book. I've never seen one, to be honest. I know John the Ophthalmos and Right Rarity have done a few historically, but the indications for this are very, very few and far between. Small duct disease, you're better off doing something else, really. And then you've got the option actually of if you've got disease in all of the glands, then you need to either do a total pancreatectomy or a near total pancreatectomy. And really, total pancreatectomy are the sort of things that we offer prophylactically for patients with PRSS1 mutations that we're worried that they're on the change and need to have all of that tissue removed, or we're worried about cancer. Whereas the near total pancreatectomies are for people with substantial whole gland disease, but you want to leave some of the pancreas behind for function. And those are split into what's called the duodenum preserving, spleen preserving total, or a near total in situ, which John Neoptolemus calls the livercado, because it looks like an avocado that's been skinned and it was developed in Liverpool. So that's basically what a DPSP-TP looks like. So you're leaving just a little bit of head and bile duct left, and everything else comes out. It preserves the spleen. And then a livercado or an in situ pancreatectomy is where you really, really carve almost everything out, but you're just leaving a very thin rim around. The latter two really are also only appropriate in people that are diabetic. But as you can see, there's lots of different options, which might lead you to think actually none of them work particularly well. But if you do have an awareness of what you're doing it for, you do therefore need more than one up your sleeve. Okay. Then that leads me swiftly on to this very interesting study, which was published in the Lancet, about is a Whipple actually the same or better than a duodenum preserving head resection? Because the contemporaneous literature at the time suggested that leaving the duodenum was better. So this was the first large-scale pan-Europe trial. And actually, on the basis of this, it does suggest there appears to be very little difference in doing a Whipple's versus a duodenum preserving pancreatic head resection. But if you read deeply and carefully into this, there are a few things that you need to just be aware of that might change your mind. It was suggested in this trial that there was a greater risk of post-operative sort of medium term after, say, 20, 30 months of biliary stenosis was higher in the duodenum preserving pancreatic head resections. But the important thing to say is there was no real quality control in this study. There were no operative photos or videos, and it wasn't specifically recommended how you dealt with the bile duct, whether you left it and just took all the tissue from around it, or whether you actively went and found the bile duct and opened it and fish mouthed it open into the head, and how much attention was paid to those vascular zones that I've spoken about before, and whether they were protected. So personally, I think it was a nice trial, but I don't really think it answered the question because of the poor methodology within it. And I can say that because my name's on there as well. And then really the next important thing came from my good colleague Bill Greenhalgh when we wrote this consensus statement for what is the risk of development of cancer from chronic pancreatitis and what are the recommendations of how we should survey these people. And this comes from this piece of pathology information. So this takes you back to medical school pathology, that whatever causes chronic inflammation, if you think about this maybe from HP, where you've always got inflammation going on, eventually there will be a change in somatic KRAS and it will form mutations. By somatic, that means that it's within your genome. It's not an inherited bit from your family. So genetic is different from somatic. Yeah. And eventually what happens over time, from the panning sort of graph over here on the right, that the cells within the acinar and the ducts change to have a metaplasia. So there's an acinar to ductal metaplasia within the pancreas, and eventually that leads to progressive accumulation of panning grades. And over time, that gives you a risk of pancreatitis. So you can see, therefore, someone with hereditary pancreatitis that gets symptoms from the age of 5, by the time they're 60, have got a really high risk of developing pancreas cancer. So then the obvious question is, we should survey everyone with chronic pancreatitis for pancreas cancer? And my response to that would be no, absolutely not. So if you look at just barn door normal sporadic pancreatitis, the risk is tiny. The incidence equals the prevalence, so it doesn't meet any of the Younger Wilson criteria for surveillance. So yes, you will find over time some people have done that, but that's just bad luck, unfortunately, and is probably not higher than the risk for the general population. And then what about all these mutants I've talked about? So I get loads of referrals every year for people with SPINK1 mutations and whether I would enter them into a surveillance pathway. Well, I don't, because again, their risk is really quite low. Having said that, it does change over time. And by the time that they're about 70, their risk has gone up significantly. But having said that, and knowing that people with a SPINK mutation, 75% of them will have developed significant calcific chronic pancreatitis by the age of 50, these should be in our clinics anyway, not under surveillance. They should be in our clinics and we should be monitoring them regardless for the progression of their chronic pancreatitis. And if anything were to come obvious in that period of time, we would pick it up. So they don't need specific surveillance, but they do need to be seen by us as surgical pancreatologists, quite common. The CFTR mutations, remember, are just a sort of helper mutation and have a very negligible risk above the normal population, don't need to be surveyed. But this is building really back up to the PRSS1 group. Their cumulative risk is greater than 44%. And by the age of 70, they really have had a massive risk of developing. So let's put that into context. It's a 70% fold increase in developing pancreas cancer and a 40% lifetime risk of developing pancreas cancer. So these are the people that we really, really, really need to put into surveillance systems. Okay. And then the last paper is actually so contemporaneous, it's not actually been published yet, although yesterday it did come out online as a pre-draft. And this is really the 25-year outcome of EuroPac, okay, which is the European Registry for Hereditary Disease. Now, obviously that looks at familial pancreas cancer, but I'm just going to focus on the group that had hereditary pancreatitis in that and have a little exploration around that. So you won't find an awful lot written in the literature about the outcomes of surveying hereditary pancreatitis. And that is because it's a small group. It's not the traditional pathology of pancreas cancer. And there's a lot of ignorance out there. And the groups that do undertake surveillance for pancreas cancer in at-risk groups, the CAPS consortium in America, the Dutch, the German systems, ignore the role of hereditary pancreatitis. In Europac, we think that is wrong, and we've always looked at them. And given the fact that they've got a huge risk, actually, it's a very valid group. And actually, the options that we have to apply to these people preventatively are quite complicated. So that's a snapshot of the 25-year experience. 900 people have been throughout surveillance on multiple rounds. But if you can see there's 855 that were familial pancreas cancer, and I'm just moving my screen here because I can't remember the number, 38 that were hereditary pancreatitis. So it's a small proportion, but remember it's important. And there's quite a lot with those famous mutations I was telling you about. There's a couple that have just got family history, and then there's one that's got a quite peculiar subvariant of R122H. But what I want you to just take a little bit of notice of is this graphic up on the right here that's split between the outcomes of what we found for the HP group and then the two familial pancreatic groups, whether they contained a mutation or whether they didn't contain a mutation. And if you have a look through all of that, all of our findings are at a really, really early stage. Okay, they're all at less than stage 2. And the two deaths, or the two that we couldn't operate on, one had a perfectly operable lesion, and that's this case here with the very long surveillance time of 22 years. But we found on her last surveillance a tiny little 1 centimeter lesion popping into the duct. And that would have been completely curable if it wasn't the fact that she was failed by the anaesthetist. This one, again, had a good prognosis tumour, but had developed portal hypertension over the years, so became inoperable. This one here, ID5, is the nephew of this one, both carrying N29I mutations. And two other relatives of that family who outside of Europac also developed cancer. But interestingly, there are another 3 patients, all with HP, that were too young to be in surveillance, a 12-year-old, a 14-year-old, and a 28-year-old that actually, within the last couple of years, have also had operations. The 28-year-old had terrible pain and ended up with a total pancreatectomy. And the 2 boys here had left pancreatectomies, both for pancreatic duct ruptures. This one also had to have a modified HACCP procedure for left-sided portal hypertension. So the point really that I'm trying to make here is that you'll operate as often in HP patients for their symptoms as you will for their risk reduction in pancreas cancer. And when you're reducing the risk or you're operating for the reasons, you have to understand what the overall outcome of these patients is and do something appropriate. So it was appropriate to take the whole pancreas out of the 28-year-old, but not appropriate to take the whole pancreas out of the 12 and the 14-year-olds. That can come later. So be careful, treat the Ds respectively, and understand that you're not just treating for the risk of future cancer, you're actually treating them for their current risk of complications. Okay. And I've purposely finished ahead of time because I was expecting a few questions. So thank you very much for listening to me.
Thank you, Prof. Halloran, for an enlightening talk. I think we've all learned a lot about chronic pancreatitis, which most of us weren't aware about, really. If you have any questions, please can you pop them onto the chat, and I'll be able to direct them to Prof. Halloran. Yeah, Q&A. That's what Sal said. Where is this? There it is. It's in a Q&A. Whilst we're waiting. Pardon?
I've frightened everyone, have I?
Uh, so I have a question actually. Um, from what age do you start surveilling them? Because you said you had to exclude the 28-year-old, for example.
40 years old. But actually we do look back through all of the family history. So if there is a lot of relatives in the family with PRSS1 that have developed cancers young, then we might knock 10 years off that. But
Okay.
usually it's older. So generally at 40.
Mm. We have a question from an anonymous person. So he says, what is the surveillance strategy after partial resections in definite HB patients?
So those would be the people that have had a left pancreatectomy or a Whipple's and have a remaining remnant. So
Mm,
they would, as follow the rest of the protocol. We don't use endoscopic ultrasound in HP because there's lots of calcifications and it will distract from what's going on. They get a CT at baseline, and then dependent on their sub risk. Which will be whether they drink alcohol, whether they're a smoker, or whether they're diabetic. They either get a CT every second year, or if they're high risk, they get a CT year one, an MR year two, and then it follows CT, MR, CT, MR, CT, MR. So we just intervene with a contrast enhanced MRI, not an MRCP, MRI pancreas.
okay.
Fortunately, it is CT heavy, but EUS has been proven to be dangerous over the years because it misses lesions that are hidden behind the acoustic shadow of chronic pancreatitic stones or parenchymal calcifications. And then
Okay, thank you.
do tumor markers and HbA1c every
So
time.
which tumor markers do you say you did?
CA 99 is the best at the moment, but um,
Hmm.
there is another platform, but I can't tell you about that. That's under copyright.
Okay, that's fine. We've got another question from Deepankar. What criteria should we use in district general hospitals before considering genetic testing in patients with multiple attacks of acute pancreatitis?
Okay, so I think if you've got multiple attacks and they're relatively young, you should send them straight off for a genetics R175 panel, which includes PRSS1, SPINK1, CFTR, and a couple of less known things that associate broadly with chronic pancreatitis. So, multiple recurrent attacks, or
Mhm.
what sounds like a good family history in multiple individuals. So it's a genomics form. You got to write R175 and put something sensible in the clinical information like recurrent pancreatitis, other causes excluded, query, hereditary syndrome. And NHS Genomics will take about 7 months to get that answer back to you.
Yeah. And where do you send it to?
You get your form from your local genomics
Yeah.
lab. They should be available in your clinic, and you just fill it in. It's an old
Okay.
paper form, unfortunately.
And we've got a question from Obi, which says, at what stage in the disease process should we be considering surgery for patients with chronic pancreatitis in sporadic patients?
Right. Okay. So it's symptomatic. It's
Mm,
symptomatic control. So as a surgeon, you're operating for pain. So it's someone that's on got a high pain score and a lot of pain relief medication. It's very important that they understand they have to have stopped drinking and they have to have stopped smoking, and hence the problem of going onto these nicotine vapes. So I've had a patient that I did
mm,
a Frey procedure on last year because he wasn't diabetic and he was a good boy and he stopped smoking his rolled up cigarettes. But because the rolled cigarettes from tobacco pouches have an unquantified amount of nicotine in them, he went straight onto 20 milligrams nicotine vape. And then this year I've had to revise him because he's got more calcification in his pancreas now than he started with the year before because of the nicotine in the vape. So you've got to be very brutal with these people. If they smoke and if they drink, they don't get an operation. That's the end of it. But it's an operation for pain or obstruction of the bile ducts or gastric outlet obstruction, those sorts of things.
mm,
But chronic pancreatitis operations are much, much, much harder than cancer operations of the pancreas. So they certainly shouldn't be undertaken by inexperienced teams or junior surgeons.
Thank you. We've got a different question. Is PD stent recommended as a test to check symptom control before drainage in chronic pancreatitis?
Yeah, you'll find a lot of literature about that, and if you speak to a gastroenterologist, you'll get a completely different answer. I wouldn't do
Mm,
it personally, um, because it's inaccurate, and all that's doing is just going across the ampulla into the very proximal duct. It's not testing what's going on behind that. So if you've got a big stone load in the duct behind that, it's not actually going to make a lot of difference, and that might be why that fails. You're unlikely to give them pancreatitis, but I don't see it as a functional, useful element personally.
yeah.
Although I do have a story from that I've seen from America where a 25-year-old got referred to a specialist centre after having had 75 ERCPs and 25 pancreatic duct stents, and all the stents were still in there. So when they looked at it, it looked like a cauliflower with all these stents coming out. So all they did was pull all the stents out, and he got instant relief because they blocked the
Yeah.
duct. So, you have got to be careful.
Interesting.
Yeah.
Any other questions at all? No. Is there anything else you'd like to add, Prof. Halloran, before you
No,
finish?
no, not really. If you want to ask me a question, you can email me, um, or ring me up, and I'm always very happy. And I get rolled out at various meetings to do similar talks, so probably catch up with some people later on in the year.
Yeah. Right. So on that note, I'm going to say thank you for taking the time, especially when you're quite busy on call as well. And I want to remind everyone that we still have one webinar next week on the 25th, and it's going to be about liver transplantation evidence in practice by Prof. Keith Roberts, and will be chaired by one of our colleagues, Dan Chan. So make sure you sign up for it, and we'll see you then. All right, thank you for your time.
Thank you all. Have a nice evening. Bye bye.
Bye, everybody. Bye.